All right. So I am very excited to chat with Dr. Jason Hawrelak, as he was actually my instructor when I went through my master's in nutrition at the University of Western States. And I'm not sure why I haven't invited him to the podcast sooner, because I've been following him for so long. And again, I just keep on mentioning his name when I'm doing my own like courses and talking to patients. So it's an honor to have Dr. Jason here, and we're going to be chatting about prebiotics, probiotics, and just the gut microbiome as a whole. And I'm going to dive into Dr. Jason's bio, and then we're going to just dive into the gut microbiome. So Dr. Jason Hawrelak is a researcher, educator, Western herbalist, and naturopathic physician with over 20 years of clinical experience. He did his Ph.D. examining the capacity of probiotics, prebiotics, and herbal medicines to modify the gastrointestinal tract microbiota, and teaches worldwide on the topics of microbiota modification and gastrointestinal health. He has published extensively in these areas, including 20 textbook chapters, and Dr. Hawrelak is on the Medical Nutrition Council of the American Society for Nutrition. And he is a fellow of both the American College of Nutrition and the Naturopaths and Herbalists Association of Australia. And Dr. Hawrelak maintains a busy clinical practice in Hobart, Tasmania, Australia, where he consults with patients from all over the world. And then additionally, Dr. Hawrelak is Chief Research Officer at probioticadvisor.com, which I must say is amazing. And that offers a searchable database that enables easy, evidence-based prescribing of probiotic products and online resources for clinicians to learn more about the human microbiome and how they can positively influence these ecosystems. And thank you so much for joining us, Dr. Jason.
You're very welcome, Eric. I'm trying to remember how long ago it was that you were a student of mine at TWS. How many years ago?
Yeah, quite a while. So I believe I specifically took your course. I think it was in the fall of 2013.
Goodness. Okay. You were definitely one of the early ones, weren't you?
Yeah. And so you no longer teach at Western States, do you? Or
Yeah. No, I'm still there.
oh, you are still okay. Was that in?
Yeah. So
did I go over the bio? I don't. Maybe maybe that was in the bio, and I just wasn't paying attention. But okay. So you do still teach. I should know this, but again, I just follow now you for your course. Yeah, I've attended your courses, your online courses, and again, you're listening to your podcast. But yeah, that's cool. So you're still teaching for them.
Yeah, no, that's one of my passions. Is actually is I thoroughly love teaching, and I love nothing more than teaching gut stuff to practitioners, because I just love the ripple effects that go out when you can actually improve the way that practitioners are engaging with their patients, improving outcomes. You have the capacity of changing the lives of tens of thousands of people, which I think is just incredible. So it's an honor and privilege, but also a great joy to teach. So and coming onto podcasts like this is like that too, because you have a chance of actually reaching so many people that you otherwise wouldn't do, and hopefully improving their lives by giving them information that they may have been waiting for, and just that now is the right time to hear it, and it changes the direction of their health. That's what we're hoping for.
Exactly. So why don't you give a little bit of your background as far as how did you start becoming an expert when it comes to gut microbiome and probiotics, and what motivated you to create the website probioticadvisor.com?
Well, some of it was probably almost chance, in that my final year of my naturopathic training, there was a lecture by one of our senior lecturers around dysbiosis and leaky gut, and it's how it drove so many other chronic diseases. This was back in 1999, and that lecture just really stirred something in me. It was like, this stuff is amazing. I really want to delve into this topic and really dig into it. So I've essentially finished off my naturopathy training, but then in Australia, we've got the capacity of doing an honors degree. An honors degree is a research-based project, and then you flow on for that to do a PhD. So that's what I did. So I did a clinical trial for an honors degree of looking at prebiotics and probiotics in irritable bowel syndrome to change the gut microbiome. So that was back in 2000, and then I followed that with my PhD. So just one of those things that maybe if I had not showed up to class that day, missed that lecture, my life would have taken a different tact. Who knows? But it was just such an exciting area, and I still find it immensely exciting. So I sort of flowed on from doing my honors degree to my PhD in the same topic of, okay, how do we change the microbiome in in patients with irritable bowel syndrome using herbal medicines, prebiotics, and probiotics. And then I started teaching clinical applications of pre and probiotics, essentially back in probably the latter bit of my honors degree, so back in 2000, to initially naturopathic students, to share kind of what I learned from spending a year devoted solely to that sort of topic. Because I learned a lot more in that than what I was certainly taught in my training, which is, we did a fair bit of stuff in traditional naturopathic training, but it just was really scratching the surface. And I think there are certain things that around things like strain specificity that we'll probably dig into soon, that was not touched upon in my training. It was like, probiotics can be used for this, this, and this, versus when you start looking into the research and really delving in there, you realize that, okay, well, yes, some probiotics are good for certain applications and some strains are good for other applications. And it really, blows your mind and changes the way that you look at using probiotics from what I tend to call the old paradigm, which was you do a stool test, oh, you're low in bifidobacteria, here, take some bifidobacteria. That was the old paradigm, versus the new paradigm is, okay, there are human clinical trials showing that, bifidobacteria strain HN019 speeds up colon transit time and softens stools. Therefore, you use it for people who are constipated, who have slow transit time. But you wouldn't use that strain for someone who has diarrhea, for example, or someone who's got a Helicobacter pylori infection. That strain's not going to help with that. This as research has really built up around probiotics, we really get to see how much differences there are between different strains, even within the same species, but how important that is in terms of our choices around what we use therapeutically as tools, and trying to make sure we're using the ones that actually have the actions required to treat the condition or the patient we're trying to help.
Yeah, I found it fascinating because that's where I learned it from you. And before that, I didn't know about, that you should use probiotic supplements with specific strains, just like a lot of other practitioners still do. I was just recommending probiotics, just really didn't know anything about probiotics until I learned with you about also that we'll talk about prebiotics, how prebiotics are important, because a lot of practitioners neglect the prebiotics as well. So so the strain, definitely want to look at the strain. So if like you're looking at a probiotic supplement and it has just like lactobacillus acidophilus or lactobacillus rhamnosus, but it's not actually giving the strain, then you just don't really know the therapeutic benefits that it has.
No, exactly. You don't. And I think in this day and age, I think it's unforgivable, I think it's the right term, for supplement companies to be only providing species level information. I think 20 years ago, when I first started, it was a bit more forgivable because the concept around strain was newer. And yes, it had been known for a while, but it was like a newish, idea that we can actually have marked differences within the same species just by by the strain designations. But I think now, if there's any company that doesn't list the strain and just has species name, I will not use it as a tool, because you just don't know what is useful for it. You don't know until you do research. That's the thing. We don't know whether it survives stomach acid. We don't know if it survives bile salt exposure, whether it adheres to the gut, whether it produces an antimicrobial compound that's helpful in the gut or detrimental in the gut, whether it has any therapeutic effect at all, unless we do research on that specific strain to see what it does in reality. Yeah, I can't help but think there's a relatively new psychobiotic, which is a probiotic that has been shown to help with mental illness. Essentially, is kind of the definition. It's hit the marketplace in the last couple of years. Lactobacillus plantarum PS128. Now that was originally isolated from a traditional Taiwanese ferment, cabbage mustard green ferment. Of which there's like 500 different types of lactic acid producing bacteria in those kind of naturally found in the ferments. But through like a lot of testing, they isolated that one strain that had what they call psychobiotic effects, that was able to actually change, when you give it to animals, it actually changed the amount of serotonin and dopamine in their brain when you gave it to them. And they took that and said, okay, we'll do the animal studies. It's pretty consistent. Now let's test it in humans. And they gave it to kids with autism spectrum disorder. And lo and behold, it decreased defiance, it decreased sort of repetitive behaviors, and it decreased anxiety. And they're using the same strain in Parkinson's disease and Tourette's syndrome and other conditions like that. I just think it's phenomenal. But that you just can't expect any random strain in that fermented food to have the same effect. It's like they isolate that one strain that had the characteristics thereafter, and a bunch of strains did not. So I think it just really puts that in perspective of that when scientists do this well and companies do this well, we end up with having this well-researched, well-characterized agent that has definitive efficacy in these conditions, versus you can go, okay, well, let's get some random L. plantarum and hope it has some impact, which is kind of where I think some practitioners practice, because they're unaware of the strain stuff. They're just like, oh, let's give some probiotics and see if they help. It's all hit and miss, and I think they're going to be missing a lot more, and the patients can be essentially suffering as a consequence of not prescribing things based on the best scientific evidence, and with the way that the information has evolved over the last 20, 30 years.
Yeah, so arguably, or maybe not arguably, I mean, according to what you mentioned, the strain, having specific strains is more important than having a higher potency, like the colony forming units. It doesn't
Definitely.
really, not to say it doesn't make a difference. You want to have, I think you said at least 1 billion like CFU as far for most of the probiotic strains, but just because something has like 100 billion CFUs, it doesn't make a difference, again, if it doesn't have like specific well-researched strains.
No. And I think I like giving this example of antibiotic-associated diarrhea. There's one study that gave lactose retried DSM-17938, which is sold around the world as BioGaia, and to these elderly people taking antibiotics. And they gave, I think it was 200 million CFU, not billion, 200 million CFU per day. Another study looking at elderly people taking antibiotics in hospital settings, the same population gave 60 billion of 2 different lactobacilli and 2 different bifidobacteria strains. Fast forward to results, the 60 billion preparation did nothing. Didn't stop antibiotic-associated diarrhea at all. Yet 200 million of that one specific strain worked amazingly well. And I always think that's such a clear example of choosing the right strain with the right actions, versus just going, let's give billions of this stuff that we don't know works or not. And it turns out it didn't work. Now, that same strain combination that didn't work for antibiotic-associated diarrhea has got some positive research for improving quality of life in irritable bowel syndrome patients. So it's not as if it's not useful in any condition. It's not useful definitively for antibiotic-associated diarrhea. Whereas the reutilized strain that we use in that study is clearly, even if it was given at like 300 times less on a daily dosage.
Now, also, so when it comes to specific strains, is this also, because a question I get from people from time to time is fermented foods. Can't I just take fermented foods instead of taking a probiotic supplement? I guess if it's for therapeutic purposes, it might be more also hit or miss, since you don't know what strains are in the fermented foods.
Yeah, because they're generally wild ferments. Now you can be very directive with your ferments, and you could use a probiotic strain with well-defined characteristics as your starter. And if there's a way of guaranteeing that's what's there at the end product, which you could sometimes you can do with different microbiome analysis labs, you can send your ferment there. You can see what's actually there. It is possible you could make a ferment based on the right strain to make sure you're getting that strain in a food base. Sure, but in terms of what most people are having, they're wild ferments. Like sauerkraut, kimchi, where we're just kind of just letting the natural bugs that are found on there ferment that cabbage. You just don't know what you're going to get. Like you're going to get, we know the species stuff fine. It's like most likely Lactobacillus plantarum, some sort of strain within that species, but it doesn't necessarily mean that it's going to have any therapeutic quality to it. Doesn't mean it's going to survive transit to the stomach, or bile acid exposure, or attach to the gut, or produce any selectively acting antimicrobial compound, or whether it might produce a antimicrobial compound that kills off your beneficial bacteria. Like you just don't know any of those things in a wild ferment. Now, I eat kombucha, or I drink kombucha, I eat kimchi and sauerkraut daily. But for me, they're just ways, one, I think they taste great. And two, I think it's a way of enhancing your immune reactivity, I would say, by interacting with different microbes from the environment, which I think is always part of what humans have done. I think it should be part of what we're still doing. And I think improving diversity of our ecosystem by having these microbes that are generally temporary visitors, but while you're eating them, you're going to get another 15, 20, 30 different species, depending how diverse that ferment is, that they're in your gut for those temporary time periods. But I think there's no way I would rely on it in the same way that I would, okay, a kid on the spectrum, I want to give the PS128 strain that we know actually changes neurotransmitters in the brain, because other strains of L. plantarum cannot. We know clearly from that data do not have that capacity. So you don't know whether you might luck out on the sauerkraut lottery, and you might end up having what we call a psychobiotic strain that randomly happened to be in your sauerkraut, but there's a decent chance you have not. But if you take the sauerkraut and you feel really happy afterwards, and maybe you've lucked out and you've won the sauerkraut lottery, and then you can keep using it as a starter culture. But I think it's just it's with wild ferments, they're just that. They're wild and they're diverse. And I think there's a strength to that. And there's a place for that in healing journeys. But I think it's not when we're really trying to target specific issues.
Okay, thanks for sharing that. And I think one thing you also mentioned is with fermented foods and the species or strains that come with them, you're not sure if it's going to survive, like for example, the stomach acid. So when it comes to commercial probiotics, are typically all of them resistant to stomach acid? Because that's a concern also with some people. If I take it, will it actually reach the desired?
Yeah. And I think this area has been probably over focused on by companies selling other probiotic preparations to try to make you wary about using lactobacilli or bifidobacteria-based ones, going, oh, well, they don't survive stomach acid anyway, so there's no point. I think it's been kind of a selling point for some other types of probiotics in the market, and it's taken hold, sadly. I think, again, if you went back 40 years ago or 30 years ago, you'd probably say that there's a decent chance that a number on the market would not meet that criteria of survival through the upper gut. You fast forward to now, any preparation that has well-characterized strains, like L. rhamnosus GG or Lactobacillus DSM 17938 or Lactobacillus plantarum 299V, we know that they survive stomach acid and bile salt exposure, and they can show up in your poo after, because they did those studies before they brought them to the marketplace. And these days scientists are generally doing these preliminary studies of going, okay, well, we'll take our 500 strains of lactobacilli from this fermented Taiwanese traditional food, and we'll put it through an obstacle course to go, does it survive bile acid exposure, stomach acid exposure, does it adhere to the gut, looking at all these different characteristics. And they might find 5 or 10 out of the 500 that do. And those ones they'll then take into animal models and then eventually into human studies, because we'll get to see what they actually do beyond just survival. So I think the ones that are actually well-defined strains, yes, they will survive transits to the stomach and small bowel very easily. I think, again, there's a risk if you're using probiotics that do not define the strain and that you have no idea what you're getting. And I think the reality is that a supplement company can buy well-characterized, well-researched strains that have got all that sort of background data done on them at a high price point, or they can buy at a low price point where some microbiologist just said, I don't know, to isolate 500 strains from, or a couple strains from the sauerkraut and start selling it because it's cheap. And we have no idea whether it actually has those basic characteristics required. So I think there's always a risk in numerous ways for buying supplements that do not define the strain characteristics. But I think we buy the ones that do have the strains and have positive clinical trials showing that they work, and we don't need to worry about whether they survive in the upper gut or not, because they know they work, and we have clinical trials showing that they work.
And then I think it was I'm almost sure it was from you, where I learned that you're supposed to take probiotics with food, just because some sources will say not to take it with food.
Yeah, I know that's one of those myths I've been trying to bust for 23 years now, Eric. Because I think the data was relatively clear back then, and it's even more clear now that we have better survival with a meal. The bacteria survive better with a meal. And this matters far more so for lactobacilli or bifidobacteria-based probiotics. Saccharomyces doesn't really matter. Bacillus doesn't really matter. And I would say with the new generation probiotics, like those based on Akkermansia or Eubacterium or Faecalibacterium, I reckon they'll be better with food too, because they're often more impacted by a really low pH. And when your stomach is empty, the pH is around 2.5. So when you're putting bacteria in there, it's really acidic. It's designed to kill bacteria, and it does that pretty well. But when you have food, the pH actually goes to 4 or 4.5. So it's obviously closer towards neutral. Still acidic, but it's certainly quite a far cry from a pH of 2.5. And we have better survival of the bacteria that go through at a pH of 4 or 4.5. And the bigger the meal, generally the more buffer the pH is. And there's even research showing that dairy dairy food actually works as a better media to transport bacteria through, because I think it buffers the pH even more so. So it provides a more neutral-ish environment for microbes to pass through the stomach intact.
Okay, so lactobacillus, bifido-based probiotics take with food, the newer probiotics as well. But then you mentioned Saccharomyces boulardii, not necessary. And then you said
No.
also bacillus, if you're taking bacillus-based, like
Yeah,
spore-based
those
probiotics.
spore-based ones don't matter. I mean, I think that's one of the strengths of the spore-based ones. I mean, you can buy some spore-based stuff that's mixed into baking kits that you buy and you bake in the oven, and other ones you add hot boiling water to a herbal tea, and that doesn't kill them. Like they're quite resilient, and then they sort of release when they're in the human gut. So that, I think, is one of the strengths of those bacillus ones, particularly, is their environmental capacity to survive in a wide variety of environmental conditions that would otherwise kill. If you pour boiling water on your bifidobacteria, they're not going to survive. You put boiling water on your Saccharomyces, they're not going to survive. But the bacillus spores, they'll survive, and they will come out, release into your gut at a later time point.
Now, sticking to the topic of bacillus spore-based probiotics, I know a few years ago, not that you aren't in favor of them, but just the research, it sounded like, was still behind, like the lactobacillus bifidobacterium. Do you still feel that way, where there's still a lot of research to be done?
Yes, and I happily use some that have clinical trials showing that they do something. Yeah, so for me, that's the indicator. If there's evidence showing that something is safe and efficacious, and we have clinical trials showing that this bacillus type probiotic works for this condition, I'll definitely use it. And I think we're certainly seeing that evidence grow. I mean, there are some, the Enterogermina strain of Bacillus clausii, I think it is, that was been on the Italian market since the 1950s, has a fair bit of research on it, over that time, mostly for immune stuff, but other conditions, antibiotic-associated issues too. That's been one of the exceptions that had a higher sort of research base. But I think in other areas, the products were being overhyped before the research was there. And I think that's the thing that triggered me a bit of going, if we have these bifidobacterium and lactobacilli-based ones with clinical trials showing that they work, and then somebody who's selling the product saying, don't use them, use mine where I've got no data for it. I was like, it just doesn't feel right to me. But I have been happy to see that the evidence base has been growing on those. And, you get ones like the Bacillus coagulans GBI, I think 6086, I think from memory. That's got an interesting research repertoire that's useful for rheumatoid arthritis, for example, and functional abdominal pain. So a couple of conditions of which there's probably less research data on other probiotic strains from the lactobacillus bifidobacteria camp. But still, if you were to compare the total amount of research on lactobacillus bifidobacteria versus some bacilli, the research on the traditional ones far exceeds what we currently have on bacillus-based ones.
All right. Let's dive into prebiotics. So can you discuss why prebiotics are so important, and perhaps some of the best food and supplement sources of prebiotics?
Yeah. So, I think the prebiotics, as you kind of alluded to before, are an underutilized tool in most people's clinical toolkit. Not for me. I was enamored by prebiotics when I started doing my honors degree back in 2000, because I don't think I was taught really anything about them in my naturopathic training. And then I started reading the studies that are even done up to that point. I'm like, oh wow, there are these things that dramatically change the microbiota in selective ways, far beyond what we're going to get with taking a probiotic or eating some fermented food. Far beyond that. You get these dramatic impact and very selective. So I think it's good looking at what is a prebiotic? It's a selectively fermented compound that encourages the growth of one or more beneficial species of bacteria in the gut to produce health benefits. That's how it's defined. So we only have a limited number of compounds that currently meet that criteria. Yeah, and that would be inulin type fructans, which we typically would call fruit oligosaccharides. Then we have galacto-oligosaccharides. Then we have lactulose, which will probably surprise many North Americans, because lactulose is one of those things that has now been I think earmarked as like a breath test substrate more than anything else, versus it's been used as a prebiotic since the 1960s. It used to be added to infant formula as a way of making it more like breast milk. So things have it's very pigeonholed in the US, I think, in a kind of negative connotation, versus when you look at the science behind it, in fact, its capacity to alter the ecosystem is fantastic. Its capacity to decrease levels of proteobacteria like E. coli or Klebsiella in the gut is unparalleled as a prebiotic. It works amazingly well. Overgrowth of Bacteroides populations, it will bring down very well. And there was a study published in 1997, which was one that really blew my mind. It was recent when I first started my honors degree a couple of years ago, that showed that we had like 1,000-fold decrease in Bacteroides populations and 100-fold decrease in E. coli populations in the gut when people took lactulose as a prebiotic. So I mean, for every 100 there's one. Every 1,000 Bacteroides there's one. It's like dramatic impact, and 100-fold increase in bifidobacteria, and 10-fold increase in lactobacilli. Like these massive sort of shifts, and that got me excited. And then clinically, you see results like that with patients where we're actually, okay, this is a dysbiotic picture. We see we can give them lactulose, and you see these dramatic, huge shifts in ecosystem composition as a result. So those three now are which we can get in supplemental form for sure, and I tend to use them primarily that way. However, we can also get food sources that contain galacto-oligosaccharides, which is primarily legumes. So we do get some galacto-oligosaccharides found in things like beets, for example, a little bit in, trying to get anything else that's it's scattered around a few things and other sort of vegetables, but the amount is tiny versus legumes. Legumes, like all legumes, you'll get a good amount of galacto-oligosaccharides, and that's what makes legumes give you gas. You get gas because of this indigestible compound called galacto-oligosaccharides, which reach the colon, feed specific beneficial members of your gut, but you do get some flatus that comes with that. And inulin type fructans we find more broadly across different foods, like onions, garlic are really rich sources that we have commonly, but also wheat, rye, barley are decent sources as well. Particularly when people eat a lot of it, which they often do with wheat products, you can get a decent dose of inulin type fructans from that, for example. But there'll be some foods that are probably less commonly eaten by us as Westerners now than our ancestors would have eaten that were quite high, like burdock root, for example. I think it's like 10% inulin phos, jicama root, yacon tubers, I think like 15%, which is a South American vegetable. And there's a number of actually traditionally consumed vegetable crops throughout North and Central and South America that were really high in inulin type fructans. So they were always a relatively high part of many people's diets who were traditionally from those areas. Chicory roots, dandelion roots, were things where people from a European background, our ancestors used to go and collect those things and consume. No longer because they taste bitter, but there's we've lost our capacity to dealing with bitter flavors as a culture. But there are large amounts of inulin type fructans within those foods, and even dandelion leaves have large amounts as well.
And do you personally take prebiotics in supplement form, or do you rely more on the food sources?
I do both, but I definitely take my inulin type fructans daily, and often partially hydrolyzed guar gum, which is a prebiotic we haven't talked about so much, that is somewhat unique because it's very good at feeding butyrate producing species in the gut. So, lactulose, galacto-oligosaccharides, we'll just say GOS, and phos for fruit oligosaccharides, they tend to feed bifidobacteria pretty consistently across the board. They also will increase another beneficial group of bacteria called Fecalibacterium, will often increase too, as well as having decrease in potentially pathogenic bacteria as well. Now, partially hydrolyzed guar gum tends to feed a range of butyrate producing species in the gut. It doesn't really lower the levels of potentially pathogenic microbes so much, so that's not a strong point, but feeding butyrate producers is. And butyrate is just such an amazing substance that, I certainly choose my diet to nurture my microbiome, and I choose my foods to feed my butyrate producers in my gut. That's the core thing of what I do. But I also supplement that with, as I said, that inulin phos, and then the partially hydrolyzed guar gum will be part of my daily regime.
And so you mentioned that prebiotics can, I think you mentioned that it can lower opportunistic or potentially pathogenic microbes.
Yep.
Is there concern that it could do the opposite? Because some are also express concern, well, prebiotics, maybe it would feed some of the different opportunistic bacteria or some pathogens.
Yeah, and I think some of this comes from, I think there was a study published in the early 2000s that suggested, let's look at fructooligosaccharides. All right. In this particular study, if you took fructooligosaccharides, or you took Klebsiella out of the ecosystem context and just put Klebsiella in a petri dish and put some FOS in there, it could grow on that FOS. All right. And people got really freaked out by this and go, oh my God, FOS feeds Klebsiella. What they didn't do is look at the other components of that study, that Klebsiella in the ecosystem of poo did not increase when FOS was added to the poo fecal slurry. Klebsiella went down. It didn't go up, it went down. And there's no human study showing that Klebsiella goes up when we actually give FOS. Yeah. So it's like taking, I think, research out of context, going, oh my God, there's an in vitro study, but we'll ignore all the human studies that show it does the opposite, which I always find a bit strange. And I think it's because FOS can cause gas and it can cause bloating and distension. So people are like, oh my God, it's feeding the bad bacteria because I'm farting more when I take it, or I get bloating and distension. Now, bloating and distension is a sign that your gut's not working well. Yeah, and that you need to do something to work out what's going on there, whether it's slow transit time, a dysbiotic environment, SIBO, small intestinal bacterial overgrowth, that's driving that you need to address. But it's not that the FOS is feeding the bad bacteria. I think that's where people sometimes go is, okay, we've got this in vitro study, and then I eat this and I get bloated and I'm in pain. Therefore, it must be feeding Klebsiella. That's why I'm in pain. That is kind of, I think, spurious logic, and it's ignoring the human studies that don't show that. And I can say from giving FOS to thousands of patients and doing pre and post poo sampling, microbiome analysis, you do not see these things go up on FOS supplementation. It's not reality.
So if someone, let's say a practitioner was to do a stool test and it showed a few opportunistic bacteria, which is common. Let's say there was like some streptococcus, staphylococcus, Klebsiella. So some practitioners might say, oh, let's give him some antimicrobials such as oregano, or, there's so many different ones out there. But would a better approach maybe to give him some prebiotics, maybe even some probiotics, do things to increase stomach acid? Or is there justification for like the antimicrobials, even if they're just opportunistic and not necessarily pathogenic?
Good question. I think it depends on what's there and how far off of normal it is too. Because I do see some people that look at the result and like, oh, the streptococcus is in the red, but it's like a tiny bit above like the normal range. I'm like, that's not problematic, really. Whereas sometimes you might have E. coli that's, 10-fold higher than the normal range. Yeah, that's problematic. And I might decide to use a combination effect. I might use probiotic like, I think either Saccharomyces cerevisiae variety Boulardii or lactose reuteride DSM-17938 that produces a compound called reuterin that can target E. coli. And I'll use lactulose, which will bring down E. coli. And then I might use a herb too, but I'm very selective. And I think this is something that came out of my research as my PhD, is that we were curious what impact different herbal antimicrobials might have on the gut ecosystem. And this is back in 2001, 2002. So we did some in vitro research at that time going, okay, well, let's grab some bacteria that were like, usual representatives of the keystone species that we knew about at that time that we could grow in petri dishes. And then we will expose them to different herbal antimicrobials. And we'll get to see whether do they only kill pathogens and leave good guys intact, or do they kill everything? Or do they kill good guys at lower concentrations and bad guys? We were really curious. And it turns out that some of those ones did do that some things like citrus seed extract just killed everything. And if anything, was more effective at killing the good bacteria than it was the pathogens. It wiped, like we use clindamycin as our positive control, which is like pretty full-on antibiotic. This wiped out clindamycin in terms of at the concentration in which it worked and just killed everything across the board. But then we had things like garlic that actually only targeted things like Candida, E. coli, but left lactobacilli and bifidobacteria alone. And we had oregano essential oil that was good at killing bifidobacteria, sadly, but lactobacilli were fine. And it did kill some pathogens too, like a wide number of pathogens. And then we had berberine containing herbs that were also good at killing bifidobacteria. lactobacillus a bit more tolerable to it and could kill some of the pathogens. It was an interesting project because it kind of really changed the way, for me, it became integral to how I viewed the way even the choice of herbs. So rather than going, okay, antibiotics kill, cause collateral damage, but herbs are fine. They're natural. They won't kill any of the good guys. It was like, hold on, that's not true. Depending on what herb we use, what form we give it in, what concentration we're giving, what dose, we can kill lots of beneficial bacteria with our herbs too. Yeah, and that really changed the way that I practiced from that point onwards. Like, I'm going to choose things that work selectively as much as I can, which thankfully is most of the time. We can choose something that will target the E. coli, but leave bifidobacteria and butyrate producers alone, or lactobacilli alone. And I think there's been more research that's come out along that vein in the last 20 years since I did mine, that around how there's certain herbs that we know that are more selective in how they work, and certain ones that are not. So I think, and I think we shouldn't underestimate the impact of the right prebiotic and the right probiotic for shifting things in the gut too. Yeah, and if it's only a minor imbalance, that's where I'll often just use dietary changes, pre and probiotic, to shift things. Now, you do get situations, like I had some patients with Crohn's disease, and 50% of their ecosystem was E. coli. 50%. And some context here, normal levels of E. coli are like 0.01%. Or 0.1%. That's the normal range of E. coli. And in these kids, I had 2 people where it's like 50% of the ecosystem. So in that case, I'm not just using prebiotics and probiotics. I am too, but I'm also using herbal medicines like pomegranate husk. And what I love about pomegranate husk is that capacity to target Klebsiella, Streptococci, E. coli, but leave butyrate producers alone, bifidobacteria alone. In fact, they go up when we utilize it. It's like, there are some herbs that are just amazing in their selectivity. And they really, when you get on board about really targeting things, trying to do things in a selective way, and putting the microbiome first, I think we end up with better results long term for our patients. And you can look at things like berberine, which we know has got that. Yeah, it does kill a range of different pathogens, but there's some interesting research that's come out about longer term use of berberine. Actually, it causes decreases in diversity of the ecosystem. It reduces butyrate producing species with longer term use, reduces bifidobacteria populations with longer term use. But importantly, actually increase levels of E. coli and Klebsiella and a bunch of nasty proteobacteria with long-term use, which I think is one of those things that should be on our clinicians' radars when we're talking about, because berberine has become one of the new, it's used for everything type supplements. But, when we're starting to do research about is it impact on the microbiome, there are some definite negative impacts with long-term use of berberine that really should be on our radar, particularly if you're starting to think about using it for cholesterol or metabolic health, where you're giving it daily for long periods of time. You need to be aware of the significant dysbiotic effects that it actually has in the gut.
That's interesting, because I know oregano oil, could be kind of harsh, and the citrus seed extract, like you mentioned, but there is a lot, and maybe I need to just dive deeper into the berberine, because they're even in the PubMed research, that if you do a search with berberine and gut microbiome, a lot of it seems to be positive. So, but again, I guess you can't argue with the research as far as, if it does affect some of the good bacteria like the bifidobacteria and possibly
and diversity and butyrate producers. But what I think was more surprising with this research, and look at the research that humans on long-term use of berberine, because I think there's a short-term things, which might be one thing, and I don't mind using berberine for short periods of time, a couple weeks, no issue. But you start giving it daily for months, I think this is where you see the more substantive negative impacts from its use. And I think also we have to, for me, it's important that we respect traditional wisdom, and that berberine containing herbs were never given to people long-term in any traditional medicine system. They're always seen as short-term use, like Coptis chinensis, used in traditional Chinese medicine, really high in berberine. It was always seen as short-term use, don't use long-term. Golden seal was always seen as short-term use, don't use it long-term, which is, more from North American Western medicine tradition. So I think that there's this wisdom that was there around these things. And then we've pulled out this really potent antimicrobial compound and gone, oh, look, it improves blood sugar control. Let's give it to everybody long-term for years. Let's not fix the diet or lifestyle. Don't do that. Let's just give them this one, magic pill. But I think we'll see that there are negative consequences to that magic pill, whether it comes from the herb or comes from a pharmaceutical lab, if we're not treating the underlying diet and lifestyle factors that actually led to that occurring. And again, I think berberine short term is fine, but I think that the data is clearly showing that there are long-term negative consequences from the microbiota perspective, unexpected, like the growth of E. coli, Klebsiella strains, and other sort of Citrobacter bloomed with long-term berberine use. And I can't help but think that maybe you get this initial suppression, and then the bacteria become resistant to it, and then they end up growing up as a consequence with continued use.
All right. Well, very interesting, and thanks for sharing that, Dr. Jason. And what are your thoughts about, speaking of just randomly killing, not that, well, just antimicrobials. What do you think about like practitioners who treat everybody for parasites? And as you know, I interviewed Dr. Nirala Jacoby. I asked her the same question. I'm sure I know what your answer will be as well. But if you could talk about just like randomly treating, like putting everybody on an anti-parasitic protocol, even if it's without berberine. Let's take berberine out of the equation and other antimicrobials. And also if you could expand even with like blastocystis hominis. Is it more commensal? Is it pathogenic? Because there's also some controversy on that as well.
There definitely is controversy around it. And I think there's also how the evidence has changed over 20 years. If you would have asked me this 20 years ago as a clinician, if I had someone who had presented with gut symptoms and a stool test that said blastocystis, I would have gone, okay, well, let's treat the blastocystis. You fast forward 20 years, no, I will not. I will work this patient up really thoroughly, and seriously 95 or even higher percentage of the time we find something else that's causing their symptoms. Generally it's SIBO. I would say most of these patients, they haven't been adequately breath tested for SIBO. They just have gut symptoms. They have, someone does a stool test going, oh, look, you've got blasto, this is the cause, and they stop their diagnostic work up there. And I think this is the biggest mistake, because it's like, and then we're going, okay, and all that focuses on this microbe, that if you start looking at recent data, you know, you'll start seeing that it's being viewed in a different light. It's being seen to be associated with better, higher quality, more diverse gut ecosystems. People are now arguing it has a apex predator role in the gut. So just like the wolves in Yellowstone National Park or great white sharks out in the ocean, they actually get the apex predator, and their job is to keep other populations in check. And if we wipe out that population, there are consequences to the broader ecosystem, allowing other species, bacterial species in this case, to become dominant, because Blastocystis is a bacteria eater. So and some people argue it helps keep Bacteroides from becoming overwhelming, which is what we tend to see in Western cultures, is this overabundance of Bacteroides, for example. And the lack of Blastocystis may be one of those reasons why. I think the crappy Western diet is probably the core reason, but I would say that it's also the connection with the lack of the species, because many people in North America take enough antibiotics, it's not there anymore. Whereas there's, I think, 1 billion people worldwide with blastocystis in their gut, and there's a lot of super duper healthy people with blasto in their gut. And I'm putting my hand up here as someone that I was doing stool test experiments, and it turns out I've got blastocystis and diabetes in my gut. Do I ever have gut symptoms? No. Do I have fatigue? No. Do you have brain fog? All these things that people attribute to that, I don't have. And you'll find that it's not just me. There's a lot of healthy people that end up having this in the gut, and it's not a problem. And I think sometimes the issue is if we stop our diagnostic workup at, okay, you've got this stool test at this and you've got symptoms, therefore that must be the cause. That, I think, is the issue. Now, I do think that there is enough data out there to suggest to me that there'll be, in rare cases, the potential that blastocystis is a problem for this patient. And I think we just have to rule out everything else first. And then I still think we focus on, you have to do that and go, okay, we rule everything else. You don't have SIBO, you don't have this, don't have that. But you do have this bug, and maybe it came from a case of travelers diarrhea. You didn't have the bug before. Now you got symptoms. Like, there'll be some stuff in the history that might make us think that this is more likely cause. I would still focus on microbiome optimization, improving the health of the gut, and then seeing how symptoms go from that point, over just trying to kill this thing. And if it was as simple as, if we had these magic tweezers that went out there and pulled it out, it wouldn't really be this discussion. But like here in Australia, there's centers that do triple antibiotic cocktails, 3 different antibiotics orally, sometimes at the same time that they do 3 antibiotics sprayed by colonoscopy, as a way of trying to get rid of this bug, because it's been blamed as the cause of this person's fatigue or brain fog or gut symptoms. And then I'm often stuck with trying to mop up. These people, the blasto's gone, but geez, they're a hell of a lot worse than what they were before, because they've completely decimated their ecosystem trying to get rid of this thing. decimated and have massive loss of diversity. So I think it's always weighing up the potential risk versus benefit with treatments. And I think when there's lack of definitive evidence showing this is a problem, then I think we've got to be very cautious about using really big guns to target it. Whereas I think if you go, okay, well, let's make your system healthier, let's make you healthier, and let's see how you feel as a consequence. It's a different way of looking at it. If you can go, can we potentially induce better behavior? Like we know with certain microbes, and it hasn't been shown with Blastocystis, but we do with certain microbes that if we make the environment more acidic, by essentially having them have more fiber or prebiotics, we actually bring out the better behavior in potentially pathogenic microbes. We can turn different genes off and on. Their ability to produce beta glucuronidase or toxic metabolites goes down. Candida, we know we can change the pH and it makes it not grow a little hyphae that can burrow into your tissue, but it stays in that bud form. So we've got enough data showing that if we can change the environment to a healthier one, we can bring out the best behavior in certain microbes and and suppress the negative behavior. So that way the bug might still be there, but it's not a problem in terms of the context of the environment.
And do you take a similar approach with H. pylori? If someone has H. pylori in the absence of symptoms, would you also say to leave it alone?
I think it would depend on the test that I did. And I think when I'm testing for H. pylori, I'm specifically doing it because I think it's causing symptoms in that patient. But I think there are a couple of stool tests out there that test it in everybody, that find it in, I reckon, like 80% of the stool tests, I can think of one lab that finds H. pylori seem to be present, which isn't correlated when I do any other sort of follow-up analysis in most of those cases. That I'm more cautious around those things of going, okay, well, if you have H. pylori that shows up on a random stool test that isn't backed up by other testing technologies like urea breath testing or scoping and looking around, or a blood test for antibodies or normal fecal antigen, those show up clear, then no, I would not treat it based on that. But if I do have patients who show up with, a positive urea breath test, generally I would, because they'd be doing that because they had symptoms consistent with H. pylori causing a problem. So I would treat it. But I think you bring up a point in that there are people out there who argue, and I agree, that there are likely benign strains of H. pylori that are completely not problematic. And there's some that are definitely are problematic. And there are certain things we can test for, like, CAG or a few other those sort of things. We go, okay, these are virulence factors that we know about now, but we don't know about all virulence factors. So I don't think we could necessarily go, okay, well, it doesn't have these two virulence factors, therefore it must be benign. I don't think we're there at that point yet. I think in another 15, 20 years, we'll have a better picture of this about when it's appropriate to treat it and when it's not. But I do think when people have upper gut symptoms consistent with this and it's present, then I will treat. But I'm also able to use selectively acting herbal medicines and dietary interventions to target it without causing major microbiome damage. So I think, again, for me, that puts in a different perspective. If every of these patients had to take triple cocktail of antibiotics or quadruple therapy to get rid of it, then I would really want much more definitive evidence that was harmful versus, okay, you take this herbal medicine for 6 weeks, eat some broccoli sprouts and drink some cranberry juice and take this probiotic, and we get like 90% sort of efficacy rate doing that, then I've got no qualms about actually going, well, let's take out the H. pylori, leaving everything else intact. That to me is close to that selective tweezering out and pulling out the microbe, but leaving everything else in a good state that we can kind of get with some things like H. pylori.
All right. Well, thanks. Thank you for sharing that. And the final question I have for you is leaky gut testing. I attended one of your online courses where you discussed some of the different testing. And I think you mentioned, again, I don't want to put words in your mouth, but zonulin, I think you said, is still not. I'll let you talk about zonulin and some of the leaky gut testing. Again, I don't want to put words in your mouth, but I think you said zonulin's not completely accurate as a marker. No,
well, I think it's been interesting watching the research in this area. And some people will poo-poo the lactulose mannitol test because, it's old technology. Well, it's accurate technology. We've been using it for a long time. It's still considered to be the gold standard by people who specialize in this area, who don't work for a lab trying to promote something else. And I think when you start looking around the data around, okay, are things like blood zonulin, like taking a blood sample looking for zonulin, does that correlate with the gold standard? And it looks like most research suggests it does not. And then more importantly, there's researchers now in the last handful of years that have looked at what is the test even looking for? And it turns out that the tests that are looking for zonulin aren't even finding zonulin. They're finding something else. they're finding, there was like some studies show it might be haptoglobulin or complement C3 or another zonulin-like compound, but it's not actually finding zonulin anyway. So it brings up like the correlation between that and the gold standard is pretty consistently poor. And two, it's not even finding what it's purported to find, which is zonulin. And some people think that we should really be tossing out every single study that's done using bloodstream zonulin and its association with leaky gut because of its poor accuracy, and because it's not even telling us that. And never mind the fact I think maybe 10% of people don't produce zonulin at all, so they will always show up as having, even if they have really bad leaky gut, but they won't have any zonulin show up. So I think it's a problematic thing. Fecal zonulin also is a similar situation. So are we actually finding zonulin or some other compound that may be similar enough to zonulin to make an assumption with, but it doesn't seem to correlate with bloodstream zonulin. In most studies, it doesn't correlate with lactose mannitol. So we do sugar probes, which we see as the gold standard, although the occasional study with fecal zonulin suggested it may correlate. So it's really mixed, but mostly negative with fecal zonulin. But blood zonulin, I think, is really questionable as a marker, and I would rely on it as a way of assessing leaky gut. And I think it's probably pushed more so in the States because lactulose is a prescription item. So it means that nutritionists, dietitians, et cetera, can't prescribe a lactose mannitol test because it's got a drug in it, from their regulatory potential. Whereas here, and pretty much every other country in the world, where lactulose is just a common over-the-counter thing that everyone has access to, that we can all prescribe this test really easily, whereas over there, you can't. Well, listen, you can if you're a medical practitioner or naturopathic in certain states, et cetera. But I think it means that there's more of a push to go, okay, well, we can't use this test. Let's see if we can find something else. But I think people have jumped on that one way, way before the data was actually supportive of it being accurate. And I think the tests were developed, and they can't even see that without even finding zonulin. I think that's a major issue. The test purports to find it. It's not. It's finding something else.
All right. No, that's really good to know. So thank you. I'm glad I asked you that question. I know I said that was my last one. Do you have time for one more?
Yep.
In 2018, when I took one of your courses, I think you mentioned that you used to use Ubiome for microbiome testing, but since then they've gone out of business. Do you currently use any companies for gut microbiome testing?
Yeah, my patient base is pretty much spread around the world, which means I have different labs, different continents that I work with, and utilizing different technologies. And I would say broadly speaking, there's probably two types of tests that I would use in practice. Tests that use 16S rRNA technology to look at the microbiome. Ubiome did that. In the States, Ombre does that now. We're called Thrive. There are limitations with it. It's but you do get a beautiful snapshot of the entirety of the ecosystem at a low price point, around the $100 mark, which I think is fantastic. And you can track changes in the key species, Bifidobacteria, Lactobacilli, Faecalibacterium, Akkermansia, butyrate producing species will all get targeted there, that we can see, and we can see the impact of our dietary changes and prebiotics really relatively quickly and inexpensively for follow-up. Yeah, there's a test in the UK called BiomeSite, which also uses 16S, which has a better microbe library and it fills in some of the gaps that we currently have with Thrive. Because Thrive or Ombre isn't particularly good at telling us about proteobacteria populations. So each of those tests has got strong and weak points. So Ombre not good with proteobacteria, for example. Can't see Bilophila, which is a bile-loving organism that produces hydrogen sulfide gas. But if we take their data and we put it through the BiomeSite library, we can see proteobacteria and we can see Bilophila. So there's ways of trying to work around some of that issue. And then there are labs that use shotgun metagenomic sequencing, which is really cool because it can go down to the species level accurately and even down to the strain level. You can tell people are taking Lactose rhamnosus GG as a probiotic because I can see it show up in their poo when they take it really clearly, which I think is pretty cool. Again, you can look at the entirety, but the cool thing about shotgun metagenomics is we get to see fungi and protozoal bugs and bacteria, and even genetic pathways too for the production of certain compounds like hydrogen sulfide gas or methane. So there's a lab here in Australia called Microbiota that uses shotgun that I do a lot of. I'd say that the major downside is the cost point. It's $300, $350 per test, which is a lot more than the $100 for the Ombre, for example. And then I also use Nirvana Biome or Cosmos ID in the States who also does shotgun as well. But again, the price point's a bit higher. But we do get more data to work with down to this, because I think one of the biggest issues with 16S, which is like Ubiome and Ombre and Biome is their species level differentiation is not so good. That we can't go, okay, what bifidobacteria species are in there, but we can when we're using shotgun techniques, so we can get that species level detail in fine nuanced ways.
Does Viome use 16S?
Viome uses shotgun metagenomic, so they use like arguably the best technology to look at the ecosystem, but as a clinician, I don't get much out of the reports. So they're more designed for the general public. You order this, it tells you to eat this food, less of that food. But in terms of telling you what the ecosystem looks like, so I could advise that patient how to modify it, I don't get the data that I need from a Viome. But the technology they're using is good.
All right. Well, thank you so much for sharing your knowledge, Dr. Jason. I'm sure there's a lot more you could talk about, but is there anything that I didn't ask you that you have a burning desire to share? Or if not, can you just like give kind of just a brief summary of where people could, what direction they should go as far as, just looking more into taking care of the gut microbiome?
Yeah, no, I think we've covered a lot of some controversial topics and a lot of good topics, which has been great. I can't overestimate the importance of looking after your microbiome and essentially changing the way you look at it as being a custodian. Like, you've got to be the custodian of this ecosystem for not only for yourself, but for future generations too, particularly if you haven't had kids yet and you're going to be passing on those microbes to your next generation. You want the ecosystem to be as diverse as possible. And I think to me that involved eating, some general tips that have to be, it's not always that straightforward to eat the way that I'm going to mention here, because sometimes we've got SIBO or irritable bowel syndrome or family bowel disease, other things that may complicate things. But in general, we're wanting to eat predominantly plants, and not completely plants necessarily. You can if you want, but predominantly plants, whole foods, high fiber, avoiding all processed foods, anything with weird food chemicals and emulsifiers, completely avoid. Olive oil, bright colors, choosing, purple potatoes, purple sweet potatoes, choosing lots of like bright colored berries, having a wide variety of rainbow of colors as you can in your diet, the widest diversity of different plant foods in your diet, lots of spices in your plant foods like cumin and coriander, get a whole mixture of different things. I think that's the key, is diversity of foodstuffs, diversity of plant foods, whole plant foods, I think, and not to be poor of me to neglect lifestyle stuff too. So get out in nature, go bushwalking, hiking out in natural environments, garden. We know that actually people who are out there organic gardening, actually pick up more microbes, have a diverse ecosystem. People that have the more diverse, the widest variety of plants growing in their garden have more diverse ecosystems in their gut, which I think is also a fascinating correlation. And since I've read that study, I've been planting out my garden like mad with as wide variety of different species as possible, so I can actually make sure I'm interacting with different plants and getting different microbes on a regular basis as well.
Yeah. Do you still recommend? I think I forgot if it was when I went through the Masters in Nutrition, your class, or the online course, where I think you said 40 different types of plant-based foods per week.
Yes, yeah, I still recommend that, because I think to me that's not that 40 is a magic number, but because 50 is arguably better, but I think that 40 is achievable for most people in terms of, okay, how many different types of plant foods are you having over that week? And to make this easier too, it's like, a Granny Smith apple, red delicious apple, Fuji apple are 3 different foods. Red quinoa, black quinoa, white quinoa would be 3 different foods. So when you look at it that way, it becomes easier to achieve that 40. But by doing so, we do see a improvement of diversity of the ecosystem. The richness of the ecosystem will improve when we're able to eat that way.
Yeah, so not just vegetables and fruits, nuts and seeds, would those also
nuts,
fall in the
seeds, legumes? Yeah, because I think legumes have been demonized more recently, yet they are absolutely fantastic for feeding the microbiome. They really are. They contain galacto-oligosaccharides. You eat adzuki beans or black beans, you're getting the beautiful polyphenols, which feed other beneficial bacteria, soluble fibers, which feed butyrate-producing species. So as a food group that actually provides a lot of nurture and nourishment for your beneficial members of your gut microbiome, those are the ones. Legumes are fantastic. I think they've just been unfairly demonized in the last 10 years, sadly.
All right. Well, where can people find out more about you? Obviously, this probioticadvisor.com.
Yep, and that's where like my probiotic database is, which is really trying to make evidence-based prescribing of probiotic easy for busy clinicians and obviously people in the general public can access the data too. And then I've got a range of courses on there too, mostly geared for practitioners because my probably main passion is actually educating clinicians to then reach more patients. But there are some courses there for the general public that are very up on health, which is a decent proportion of people these days. Like that's one thing that's changed a lot in the last 20 years is people's general knowledge who have a health interest is just way beyond where it was 20 years ago. So we do have courses for those people too.
All right. Well, thank you again, Dr. Jason, for your time. I appreciate you sharing your knowledge with regards to prebiotics, probiotics, and the gut microbiome.
You're very welcome. Nice chatting with you, Eric.